Okay, so in the interest of time, I think we'll go ahead and get started. Welcome everyone to today's Introduction to the Indian Healthcare Delivery and Public Health Systems webinar. My name is Patrick Ahern with RTI, and I'll be helping out with the virtual room today. So please note when you log in, your microphone and web camera will be automatically muted. If you have any questions for our panelists, please submit those into the Q&A window at any time during the session. And note that you do have the option there to submit your question anonymously if you'd prefer. And if you happen to run any issues with the Zoom today, please use the Q&A window as well, and I can help troubleshoot. So at this time, Rebecca, I will turn the session over to you. Thank you.
Thank you, Patrick. Good morning and good afternoon. My name is Rebecca Perry. I'm joining you from the native lands of the Anacostan and Piscataway people. I work in RTI's Community Health and Implementation Research Program. My pronouns are she and her. I am joined today by an incredible panel of tribal health experts. Today's panel will begin with an overview of the tribal health system provided by Dr. Weiser. Following Dr. Weiser's presentation, each panelist will introduce themselves. We have a set of questions that we've developed to help guide today's discussion. So we will begin by asking our panelists our questions. For each question, I will identify one of the respondents and then ask everyone on the panel to offer their insights and perspectives. For our last question, we will have a discussion between the panelists, and then we'll open up our discussion to the audience questions. As Patrick mentioned, you can feel free to include your questions in the Q&A box, and we will try our best to address everyone's questions. I would like to ask Dr. Weiser, before he begins his presentation, to please introduce yourself. Thank you again for joining.
Thank you, Rebecca, and good afternoon and good morning to everyone. I'm Tom Weiser. I'm a medical epidemiologist with the Portland Area Indian Health Service. I'm based here in Portland, and I work with the Northwest Portland Area Indian Health Board in the Tribal Epidemiology Center. So much of my remarks will be kind of focusing on our Tribal Epidemiology Center as examples. I have been working with Indian Health Service for most of my public health service career, minus the 2 years I spent with CDC in the Epidemic Intelligence Service. And I've been at this current position since 2007. And I feel like I have probably one of the best jobs I could ever hope for. I'm really lucky to work with a very talented group of colleagues and have a lot of opportunities to work with tribes and with tribal organizations. So thank you. And I think we'll have some slides. So I'm just going to give an introduction to sort of the structure of the Indian healthcare delivery system and the public health systems that we interact with. I'm hitting the mute button and saying next slide, please. So there's a map here that shows the Indian Health Service and how it's divided the Indian Health Service into different regions. The IHS provides a comprehensive health service delivery system for about 2.6 million American Indian Alaska Native people, belonging to 574 federally recognized tribes in 37 states. There are 12 different areas, and each of these areas is mostly representing tribes in a group of states. The exception to that really is the Navajo area, which serves only the Navajo Nation. Next slide, please. So the Indian Health Service, the Indian Self-Determination and Education Assistance Act, known as Public Law 93-638, or commonly just 638, gives tribes the authority to contract with the federal government for the administration and operation of certain federal programs which provide services to tribes and their members. This means that tribes and tribal organizations can use the money that IHS has budgeted for personnel, clinical services, or other services, and use it to administer their own clinical or other programs. Tribes can choose to administer all or just some of these services. For example, they can administer the behavioral health services or the environmental health services and leave the clinical services still operated by IHS. Over time, more and more tribes have opted for self-determination and self-governance of IHS services. And in the Portland area IHS region where I work, tribes administer all but 5 of the clinical operations. And even in those areas where the federal government is still operating the clinical services, tribes are often operating behavioral health or environmental health services and other services. And this all happens through self-determination contracts or self-governance compacts. Next slide, please. Public Law 638 creates the basis for the current structure of the Indian healthcare delivery system. And the system has 3 main components: clinical programs and services that are operated directly by the IHS, clinical programs that are tribally operated, and urban Indian health programs. And together we refer to these with the acronym ITU. Eligibility for healthcare services at an ITU facility is generally based on membership in or descendancy from a federally recognized tribe. Many of the urban Indian organization clinics are actually also funded through the federally qualified health center funding stream. And because of that, there is no requirement to be native or descended from native tribes to receive services for the urban Indian clinics. But since tribal membership and enrollment varies by tribe, this will be a little bit different in each facility, each tribe. Payment of care in emergency departments, hospitals, and providers outside of the ITU system adds another layer of complexity. The IHS manages the purchased or referred care system to pay for this outside care, but only for those living on or near the reservation in which they are enrolled. This eligibility area is similar to the catchment area for a private healthcare system and is often referred to as the purchased and referred care delivery area, or PERCDA, not the greatest acronym. Furthermore, under this PRC system, IHS is the payer of last resort. So private health insurance, Medicare, or Medicaid are used to pay for healthcare services at outside facilities before IHS payments will be made. This tiered payment system also means that AIAN healthcare and health data can be spread across multiple sources. And finally, it should come as no surprise that not all American Indian Alaskan people seek healthcare services at ITU facilities. Next slide, please. So why does this matter for public health? Whether a clinic or program is designated as IHS direct service, tribally operated, or urban, can impact the electronic health record system that's used at a particular facility. And the type of EHR system affects the type and quality and quantity of data that's reported to IHS. Tribes can report as much or as little data as they wish, while IHS sites must report all data regularly. It can also impact the rules that are governing the use of certain clinical, environmental health, or behavioral health services, and other aspects of tribal health that are relevant to public health data, public health emergency response, or both. Hopefully this helps to illustrate the relevance of understanding how the system is organized and how it's relevant to working in tribal public health. Self-determination through the Public Law 638 is vital to tribal sovereignty, and each tribe has a different approach to how they exercise their sovereign rights. Next slide, please. So these discussions should always begin with the recognition that tribal nations are sovereign, and each level of the U.S. public health system can and should develop a government-to-government relationship with tribes. Some tribes prefer to work with their local health jurisdictions, which then work with the state. Some prefer to work directly with the state, and others prefer to work directly with the federal government. So we can use an example of infectious disease reporting to kind of illustrate this. So it is voluntary for tribes to report to state surveillance systems. Having said that, I'll also note that most tribes do report to state surveillance systems. However, all the IHS facilities report notifiable conditions to state health departments, and non-tribal providers, hospitals, and laboratories also have to report notifiable conditions to state or territorial jurisdictions. In addition, some tribes have established public health codes that allow such reporting of individually identifiable data to state health departments from tribal health providers and hospitals. So as you can see, whether American Indian Alaska Native data ends up in a state surveillance system will depend on several factors. Is the clinic where the person received care operated by IHS or by tribes or an urban clinic? Is the laboratory private? Does the tribe have public health codes to allow reporting for states? This is just one example demonstrating potential gaps in the availability of American Indian Alaska Native specific health data in existing US public health surveillance systems. Next slide. Finally, to bring us into the discussion of tribal epidemiology centers, the Affordable Care Act and the Indian Healthcare Improvement Act are also important pieces of legislation for the tribal public health system. In 1992, amendments to the Indian Healthcare Improvement Act authorized the establishment of tribal epidemiology centers to serve each IHS region. The tribal epidemiology centers, or TECs, were created in response to increasing severity and costly health disparities between the American Indian Alaska Native population and other races and ethnicities. TECs began their work a few years after the legislation was enacted in 1996. In 2010, Congress enacted the Patient Protection and Affordable Care Act, which permanently reauthorized the Indian Healthcare Improvement Act. The reauthorization included a provision designated TECs as public health authorities and authorizing TEC access to data held by the US Department of Health and Human Services. However, some states point out that the public health authority only applies to federal data and not state data. Next slide, please. And next slide, please. So tribal epidemiology centers are Indian Health Service funded organizations who serve tribal and urban communities. The tribal epidemiology centers get their core funding from IHS. A lot of the funding for their projects and programs are obtained through grant funding. There are 12 TECs across the US, and one of which focuses exclusively on urban Indian health. Tribal epicenters are located within representative tribal organizations which act under a cooperative agreement with IHS. While all TECs serve a common mission, governance of each of the tribal epidemiology centers and their parent organizations is unique and is guided by the tribes they serve. Most TECs serve multiple tribes in their region. For example, the Northwest Tribal Epidemiology Center is housed under the Northwest Portland Area Indian Health Board. The membership of the board is made up of representatives from all 43 federally recognized tribes in the 3 states we serve in Idaho, Oregon, and Washington. One exception is the Navajo Epidemiology Center, which is located within the Navajo Department of Health and serves only the Navajo Nation. There's a website link here at the bottom of the slide where you can learn more about the TECs and the TECs work. Next slide, please. So the Indian Healthcare Improvement Act mandates that TECs perform a variety of functions in consultation with and on the request of Indian tribes, tribal organizations, and urban Indian organizations to elevate the health status of tribal and urban Indian communities. They do this by providing 7 core functions abbreviated on this slide. Each TEC performs these functions in their own unique way to meet the needs of the tribes they serve. Next slide, please. I'll share a couple of examples from our Northwest Tribal Epidemiology Center to illustrate some of the variety of things that we work on. So the IDEA Northwest project is probably one of our most data-heavy projects at the Northwest Tech. And it works to reduce American Indian Alaska Native misclassification in public health data systems and provide Northwest tribes with local level health data. The project conducts record linkages to correct misclassified American Indian Alaska Native records in state surveillance systems such as cancer registries, vital statistics, hospital discharge data, trauma registries, and communicable disease systems. They then analyze and provide tribes with data for use in community health assessments, planning, grant writing, policy development, and also publish their research in peer-reviewed journals. The immunization program works with all IHS and tribal clinics in Idaho, Oregon, and Washington, and provides technical assistance in vaccination practices and reporting vaccination data to IHS and state immunization information systems. The Indian Country ECHO is a spin-off of the groundbreaking work piloted by the University of New Mexico Project ECHO program, which stands for Extension for Community Healthcare Outcomes. Indian Country Echo provides didactic sessions and peer learning to ITU clinics nationwide, covering a wide range of topics that include COVID-19, HIV/AIDS, hepatitis C, substance use disorders, two-spirit and LGBTQ+ health, and maternal child health. And we have a number of other projects that are ongoing, and the opportunities to impact health in our tribal communities, I think, is unparalleled through the Tribal Epicenter program. Next slide, please. Just want to say a little bit about some of the data sources that are available to us at our Tribal Epicenter. We have access to a variety of both clinical data sources and public health data sources. And some of these are listed on this slide. Each year, there seems to be a new data source or new data sources that become available and that can be accessed. And we're fortunate to have strong partnerships with state health departments in each of our 3 states, with the Portland Area Indian Health Service, and with other federal partners like CDC, SAMHSA, and NIH. One of the data sources that we have access to is the IHS Epidemiology, and all of the tribal epicenters have data through this system. But one of the recent limitations to that data is that it does not contain privacy part 2 data on substance abuse. And the data that gets entered into this Epidemiology is not systematically collected from all the sites. In addition, we can access patient medical record data held by tribes and IHS sites when we have established data sharing agreements in place between the tribes and the epicenter. The biggest limitation to accessing this kind of clinical data is that not every site is using the same type of electronic health record, and not every site has in-house capability for generating the kind of public health data that we would like to be able to use. So I'll stop there, and thank you very much for listening, and I think we'll go on to some of our questions and answers. Thank you.
Thank you, Dr. Weiser. I will now open it up to the panel. Before we launch into our first question, I'd like to turn it to Jessica Lustin to introduce herself. Please go ahead, Ms. Lustin.
Oh, if we can move to the next slide, you'll see the picture. I'm sorry.
Absolutely.
Amasa ni Jessica Diwayu. Hello, my name is Jessica Lustin. I use she, her pronouns. My mother's side of the family comes to Turtle Island from Germany, England, and France. And my father's side of the family comes from Austria, Finland, and Simpson from Southeast Alaska, originally from British Columbia. I work at the Northwest Portland Area Indian Health Board within their Tribal Epidemiology Center. I'm the clinical programs director there, and underneath me sits the ECHO program that Tom was talking about, and 2S LGBTQ work, as well as some behavioral health work. And I think what brought me into public health is a sense of wanting to ensure that we take care of each other and ourselves as Native people and tribal people. And I feel like what I think about when I say that, which is an Alutiiq cultural value from Alaska, is the story of the raven bringing light into the world. And instead of light, having that be health, and having health not be just for some people, but for all people.
Thank you, Ms. Lustin. Dr. Bell, would you mind introducing yourself?
Yes, thank you, Rebecca. My name is Ronnie Bell. I'm a enrolled member of the Lumbee tribe of Eastern North Carolina. I am a professor in the Department of Social Sciences and Health Policy at the Wake Forest School of Medicine and the director of the Office of Cancer Health Equity at the Wake Forest Baptist Comprehensive Cancer Center. I came to this work primarily because of my personal interest to learn more about the health issues that were impacting my tribe and the other tribes in North Carolina. We have 8 state and federally recognized tribes here in North Carolina. And so I was very passionate about understanding those issues. I have a brother who is a physician, a pediatrician, former president of the American Association of American Indian Physicians. And so I wanted to do what I could from a research perspective to better understand some of these issues and really work with policymakers to try to address some of these issues.
Thank you, Dr. Bell. Next, I would like Dr. Gonzalez to introduce himself.
Good morning, and thanks for having me here. I see that I must start with a disclaimer that I have not been given the privilege to speak on behalf of any of the nations that I work for, and any of the statements that are here today are mine and do not represent the views of my employer. However, I'm a firm believer of my agency's vision, and that's what inspires me to work every day and guide my responses to enhance the quality of life for all Native people. So with that, Jorge Gonzalez, as I was just attempt to introduce myself, I'm a physician by training, a public health practitioner by choice. I'm the Great Lakes Intertribal Epicenter director and work sometimes as medical epidemiologist. We have the honor to serve the 34 nations in Wisconsin, Michigan, and Minnesota, and 6 urban centers, including the one in Chicago. I'm just honored just to be here in the beautiful land of Lac de Flambeau, Band of Lake Superior Chippewa Indians in northern Wisconsin. And what brought me to my current work, I have been able to work in almost every single level of public health in this country for 19 years. And I'm funny enough, and people just open their eyes, but I'm an indigenous person from South America. Depends, definition from CDC or definition from US Census Bureau. And we quantify that 47% indigenous, 42 from Spain. That matched what I was told. And I wanted to do what I didn't have opportunity to do back in the country that I was born, that was work with tribal people full time. Thank you.
Thank you, Dr. Gonzalez. Dr. Evans, would you introduce yourself?
Sure. Hello, everybody. My name is Molly Evans. Thank you for this opportunity to present on this panel. I'm a medical officer in the CDC's Division of Global HIV and TB, but that is not where I work with American Indians and Alaska Natives. My work at CDC has mostly been on the COVID-19 response with tribal nations, and then before that on the opioid overdose epidemic, working with tribes and tribal epicenters. What led me to public health is that before I came to CDC, I worked for the Indian Health Service as a clinician on the Navajo Nation. And I was really touched by all of the stories of my patients. And I really wanted to better understand the social determinants of health and the influences of historical trauma and all of the other factors that were sort of leading people to have the health problems that they had. And so because of that, I decided to get some further training by going to the CDC and focusing my work, at every opportunity that I have to work with tribes when I'm in my work at CDC. Thanks.
Thank you, Dr. Evans. So let's start our discussion by talking about the data sources that you or your organizations use to work in tribal public health. Dr. Gonzalez, would you start us off?
Yes, thank you. And again, this will be a convoluted answer. Just bear with me. As I say, I have worked in almost every single level in public health, and I have the fortune of knowing most, if not all, of the sources available to public health practitioners. But as Dr. Weiser say, texts and tribes are similar but different. I mean, it doesn't matter if you are neighboring tech or neighboring tribe, you have totally different capacities, if we can say that. So I was acquainted with many different sources. I participated in syndromic surveillance, national level, district level, state level, all those, doing analysis, doing work for each example as the Zika response in Florida. But I've been here for 3 years, but I'm still attempting to recover from the shock when I came here. And there you go. I was just wanting to do my first analysis always when I arrive somewhere is to do my first 10 causes of morbidity and mortality and do an in-depth analysis so we know where we stand. And I discovered that we didn't have data specific from each of the tribes or from our region, and we have to access data that is publicly available. So, I mean, this is not an argument or just talking about anybody, but most of the time we use basically publicly available data. We do some projects that they are ad hoc, just requested by each of the tribes, because we also are true believers on that the needs and the questions should come from the tribe. So we accommodate and we able just to figure out what to do. However, this is changing and hopefully it will change and we will start just having more exclusive and dedicated data coming and just coming out from our tribal nations.
Thank you, Dr. Gonzalez. Ms. Lustin, would you care to share the data sources that you use in your work in tribal public health?
Yeah, thank you. So in my role, we use both national and local data. I work mainly in HIV and hepatitis C and sexually transmitted infections, which are all reportable diseases. So the Centers for Disease Control data is very helpful, although the time it takes to publish most recent data is oftentimes a problem for us if we want to, look at outbreaks or something, but I know that it takes time to do that. But because we have access to these data, we have been able to cite a huge disparity in hepatitis C related mortality among American Indian Alaska Native people. And we've been able to use that data to seek funding and to develop programming. We can also distill data at the state level with most states that are in relationship with us. And that can help us identify priority areas and allocate program resources there too. And then at the local level, the data are much more complete and it's often accompanied by important qualitative information from tribal, clinical, and non-clinical counterparts. And these data will really help us understand priorities and comorbidities that exist locally. For example, they help track trends around new diagnoses for hepatitis C and the need for MOUD or harm reduction programs that we can then seek in local areas. And lastly, we also create our data through research and partnerships. For instance, the Northwest Portland Area Indian Health Board has been able to partner with states to create more complete data by addressing racial misclassification and seeing differences in numbers up to 40%. And we also create qualitative data sets by interviews or survey to help distill facilitators or barriers for treating HIV or starting a person on PrEP, for example, or knowledge, attitudes, and beliefs from people who inject drugs on access to harm reduction services. So I think we have a lot of data available to us, some that we get from the outside and some that we create from the inside.
Thank you so much. Dr. Bell, could you please add to this question?
Yeah, so as I mentioned when I started, we have 8 state or federally recognized tribes here in North Carolina. We have a relatively large American Indian population in North Carolina. We have the largest population in the eastern United States, but 90% of our population is not federally recognized, and so we do, with the exception of the Eastern Band Cherokee in the western part of the state, our state recognized tribes trying to identify public health data, health outcomes data is available, at the local level through the local health department, or if you have a partnership with a private or public healthcare facility. We have had the opportunity to collect qualitative data with our tribes through a talking circle model, and we were able to hear from tribal members and tribal leaders about their health priorities. So this was prior to COVID, so I imagine a lot of that has changed. I will say that our State Center for Health Statistics, which is in our Division of Public Health, has done a really good job in the last 10 to 15 years in trying to get American Indian specific data for different health outcomes. In years past, and I've been doing this for about 30 years, and in years past, when I went to the Division of Public Health to get data specific for American Indians, the best I could get was white, black, and other, or white and non-white. And now there seems to be more of an intentional effort to get data specific to American Indians. And even more recently with COVID vaccination, we're getting data at the tribal level. So that's a really nice benefit that having these conversations with leadership at the state government level has, I think, reaped this this opportunity to have richer data to inform policy for our tribes.
Thank you, Dr. Bell. Dr. Weiser, could you share a bit about the data sources that you use? I know you presented some in your presentation, but could you share a little bit more?
Sure, I'll try to be brief so that others have a chance to chime in on other questions. But one of the key things, I mentioned this in the presentation, where we do data linkages, and that's been one of the key data sources that we're able to use. So we work with the states to get to have agreements with the state to have access to various data sets that they have. And then we have an agreement with Indian Health Service to be able to use a listing of those who have been seen in our region and who are native because they have achieved the eligibility to be seen in our clinics. And we link that information with the state system. And when we do that, we flag the record in the state system so that the state can have a better way of identifying American Indian Alaska Native matches from that linkage. Whether the state uses that or not, it's up to the state. They don't usually correct or change their data, but then we retain a data set that becomes de-identified at that point for doing the data analysis. So I think that that has been one of the most fruitful methodologies that we've been using. And I think it's something that all techs hopefully will be able to begin using or have been able to use as a way of getting access to that data that normally, like Dr. Bell said, is normally just white, black, and other, and not often granular enough to be able to identify who's American Indian, Alaska Native in those publicly available data sets. So that's probably the main thing that we work with.
Thank you, Dr. Weiser. Dr. Evans, would you kind of share, I want to say, bring this question or conclude this question with the perspective from the CDC, which collects a lot of different data sources, but in particular, we're curious about tribal public health focused data sources.
Sure. So, CDC does not have access to tribal data unless we're invited by the tribe and we have a written memorandum of understanding. So anytime we would be accessing tribal data would only be at the invitation of the tribe. So we've done this several times in the context of the COVID-19 response. We've worked with several tribes who have wanted the CDC to help, identify cases and sort of define what the COVID-19 landscape looks like. And so they have given us access to their data, and we've signed memorandums of understanding. But usually those agreements have to be very clear in the beginning, and it's only by invitation. So otherwise we don't have that access. We do have access. Tom had mentioned his the data warehouse that IHS has. So CDC does have a copy of the IHS's National Patient Information Reporting System, or NIPERS as it's called. This is very high level aggregate data that we can look at geographic areas. And anytime we use that data, we use it with permission and with collaboration with the IHS. We are not allowed to, manipulate or do anything with that data unless we've been invited by the IHS or, are collaborating actively with them. So we do have very different access to data, I think, than the rest of the group here, but we're able to work closely with tribes and collaborate with them and get these agreements so that we can offer assistance when it's requested.
Thank you, Dr. Evans. That actually feeds into our next question around challenges or obstacles that stand in the way of collecting public health data for and about tribal populations. Ms. Lustin, would you mind starting us off and kind of sharing some of the challenges and obstacles that you've observed?
Yes, of course. And I apologize, my sisters have a conversation going about using sunscreen or not on a baby, so I might get dings. So I think that racial misclassification is probably one of the biggest obstacles regarding data for American Indian and Alaska Native people. Current standard data collection practices by many federal, state, and local entities can effectively omit or misclassify American Indian and Alaska Native people. And this happens in both rural and in urban spaces. Two major problems with that are seen in the data collection itself, and include that they can include like multiple descriptions of Native people or definitions of Native people found in sources between state, federal, and local public health entities, and different methodologies for collection and analysis and presentation of these data sets. For example, in presentations that omit American Indian and Alaska Native when presenting on other racial and ethnic groups. And this happens often still. The Urban Indian Health Institute actually has done such important work in this space and have in-depth suggestions on how to improve this, such as allowing the collection of multiple races in different spaces, reporting American Indian, Alaska Native that include alone or in combination with other races. And also in some cases, a collection of American Indian data that's not monolith and actually collects tribal affiliation, including tribes that are not federally recognized. So this is done in circumstances with, tribal approval or input, but racial misclassification is huge, and I'll include a couple of links in the chat. Also, another challenge collecting or developing public health data is just within conducting research with tribal communities and tribal organizations. It takes time and intentional effort to not just do a project for a tribal community, and instead really developing a relationship with tribes and tribal organizations to conduct a project with tribal communities. And working in that arena, you see right away from an initial meeting or greeting, what kind of research that organization or person, what their approach is, whether it's within good relation or no relation. And that relationship can often take time to develop. Trust isn't easily given by American Indian and Alaska Native people. So that relationship can sometimes take years to develop. So a lot of organizations aren't going to put in that time to develop meaningful relationships with tribes or tribal organizations. And then also there can be multiple levels of approval needed to begin researching with tribes and tribal organizations, not only through the various IRB processes, but tribal processes, and the time it takes to handle the contracts or payment or paperwork that goes along with that work. There might not be capacity to deal with the constant go backs between, say, my organization and another organization that could be requesting like contract amendments. I'm doing those contract amendments as well as doing this other work because there isn't a person that does those at our organization. And it takes a long time. And lastly, sorry, I'm talking a lot here, but a very real barrier is racism. Just very simply not acknowledging or understanding tribal sovereignty, not taking the time to know how to say a tribe's name right. You can just ask them if you don't know how to pronounce it. So I think covert racism is very apparent, and it needs to be addressed as well when talking about building relations to do tribal health data and research.
Thank you, Ms. Lustin, and thank you for that perspective. Really appreciated. Dr. Bell, would you mind sharing some of the challenges that you've encountered, whether it be through your cancer research or even with the Lumbee people as a non-federally recognized tribe?
Yeah, so certainly I would echo what Jessica said about racial misclassification. That's a pretty significant issue here in our state. There was an analysis that was done in 2008 that showed racial misclassification of American Indians led to a underestimation of the cancer incidence rate of 19%. And so that's certainly something that we're aware of in our state. Our executive director for our state Indian Commission has been very vocal about that at the policy level. I would say the other issue is that many of our tribes are very small. And so for a lot of health outcomes, it's difficult to get stable estimates of those outcomes. And so when tribal leadership comes to me or comes to someone at the state and says, I want data on, cancer rates or diabetes or whatever health outcome they're interested in, you simply can't, you're not confident enough statistically to look at those data because of the small numbers. And I would say the other thing too is that there's a lot of health outcomes that we just don't have data for. There's a lot of mental health, for example, is one that's very difficult to get really good data on, or even oral health. We know the importance of oral health to overall health, and so there's just a lot of gaps in what data is available to our tribal citizens.
Thank you, Dr. Bell. Dr. Weiser, would you mind sharing your perspective on this question?
Yeah, I think one of the things that we've had discussions with various tribes in the past about is defining the community. Is the community just the enrolled tribal members who live on the reservation? Does it include the enrolled tribal members who live all over in other places? Does it include other Native people who live on the reservation? What about non-Native people who live on the reservation? There's all these different ways to try to understand and describe the community that might be at risk for the same thing. For example, if it's dealing with toxicity in the water or in the air, that's going to affect everyone in the community. And so we've talked a lot about that. And I think when I think about how tribes responded to COVID-19, in some ways we kind of got a new or better answer, which is, yeah, we want to take care of everybody. Many of the tribes in our area said, yeah, we definitely want to provide vaccines and testing for our tribal members, but they're not the only ones who live here. And they immediately reached out and said, it doesn't matter whether you're a tribal member or not, come here, we'll provide testing, we'll provide vaccines. And we saw that over and over again. So I think, when tribes want specific data, then it becomes a real challenge to say, well, is it for just the tribal members who live where you live, or is it, who does it all include? And that's going to be different for each project, for each tribe. But it's a discussion I think you have to have at the beginning.
Dr. Evans, do you in your role at the CDC, thank you, Dr. Weiser, do you in your role at the CDC ever encounter challenges and obstacles collecting public health data? And if so, can you share about them as it relates to tribal populations?
Sure, thank you. Well, I want to echo what others have already said about the racial misclassification. I think that is a major issue that's kind of been a common theme. But the other point that I want to make is just that, as I had said before about data use agreements and these memorandums of understanding and having access to data, I think that what happened during COVID-19 is that, these are processes that take a very long time. As Jessica mentioned, it takes building trust. You want to know that data stewardship will be respected and that tribal sovereignty will be respected when, an agency like the CDC is working with data. But what we saw in COVID-19 is that those some places had good relationships in place and had good communication between the tribe and the state, or the tribe and the tribal epicenter, and other places did not have those agreements and were completely working in silos. And I think for the places that were working in silos, they had many more obstacles rapidly responding to COVID-19. And so my hope is that with this pandemic, that maybe more of those agreements have been put in place, that there are better partnerships between states and tribes and tribal epicenters, tribal epicenters and states, and all of them with the IHS, and all of these various overlapping groups of people that need to work together, and all who really need to respect and understand that they have to respect the tribal sovereignty, and that it really is up to the tribe who they want to share their data with. But then we see in a public health emergency that it can just be challenging if that data sharing is not happening.
Thank you, Dr. Evans. Dr. Gonzalez, do you want to share a perspective on this question as well?
Yes, I will be very brief. I in agreement with all my colleagues. Small area analysis, small number analysis, on a stable denominator. So that's the nightmare for us, just trying to count any data. And I will introduce something that is just quite controversial, if I say, please, all of the presenters, excuse me, and just to the idea that the misclassification, it will take longer and more efforts than usual, because Native American, and if you ask and you check, Native American is not a race or an ethnicity, is a political status that is intimately ligated, attached to sovereignty. So we start the classification wrong on how we collect the data and how we apply it, and even sometimes analyze the data. So that's just only for all of you to think about it. But I will say that infrastructure, how do we, a challenge to collect the data is not just simply the way that it is more the way that we collect the data. So the states have, we have access to some of the data sources that CDC has, and it's okay, but all of you epidemiologists, that you don't feel comfortable with data that somebody else collected. So it's like, you accept it with a grain of salt and everything starts just looking really weird. But anyway, so as I say before, everybody is different. So I think that we need, for example, surveillance systems that they are tailored to our tribes, reliable, that they are widely used. And for example, the EHRs are a really good source of surveillance and data. And we need an EHR that is stable across all the nations, or something that is just similar. So that will help us to capture data. So I will do a little commercial. They didn't pay me for this, but for CDC, one of our grants is the tech fee, the Tribal Epidemiology Center Public Health Infrastructure, and that's one of the that grant just gave me all the emotion, because it's a structure, but it's not a structure. And for example, as we're working on creating a platform, a data platform, where we're gonna bring all, I call it my mini biosense, or biosense for the area. We're gonna bring all the data that is available and parse to the tribes, so they will be able just to access data. To me, it's not me or my analysis or anything like that, is to have the chance to give tribes and tribal leadership the opportunity to get data on a timely and efficient way. So there you go, that's me.
Thank you, Dr. Gonzalez. And getting data in a timely and efficient way also, I think, ties into funding for that data collection, as well as the research that's associated with it. And I want to start off with Dr. Bell. I was hoping you could shed some light on the accessibility of research funding to study public health issues among tribal populations.
Sorry, I was trying to be a good citizen and stay on mute and couldn't unmute. Yeah, so I think it's actually better now. I think because of the emphasis, at least at the federal level, on issues around health equity. I think that has, and I would say too, with how COVID has sort of shined a light on these equity issues, I think that has led to a greater awareness of the need for research and for health outcomes data. And so is it where it needs to be? Probably not, but I would say that we're probably in a better place than we were 10 or 15 years ago. I would say too, at least in our state, there is more funding, research funding available from, and it's both research and programmatic funding from health insurers, from some of our foundations. They don't necessarily like for you to say you're doing research, but a lot of it does look like research. So I've seen a greater emphasis on providing funds, not necessarily earmarked, but where priority would be given to work done in tribal communities.
Dr. Weiser, would you share your perspective on the accessibility of research funding for public health issues among tribal populations?
Yeah, I think one of the things I'll just mention is something called the NARCH program, the Native American Research Centers for Health. So that's a partnership with NIH, and they have been providing funding directly to tribal organizations and tribes for a number of years now to help advance research and research capacity in Native communities. So I think that's probably one of the things that has an established history now. I don't know if it's getting more funding, if it's growing or shrinking. The benefit I have as being a federal employee is I can't write grants, and I'm not in that section of the epicenter work. Probably Ms. Lustin and others could better answer, but certainly there are a number of grants that have been coming from different federal agencies, and also private partnerships too. Groups like the Kaiser Foundation, the Gates Foundation have also funded research in Indian country in the most recent years.
Thank you, Dr. Weiser. Dr. Evans, anything to add from the perspective of the CDC?
Sure. So CDC funds mostly programmatic work and, public health implementation, science, and less so like basic research. I think one of the challenges sometimes is just that the funding is very streamlined, or it's very specific for certain diseases or priorities that the CDC has. So for example, with opioids, CDC had millions of dollars to share with tribes and tribal epicenters. And for some tribes, that was very important and it was a priority issue. And for others, it was maybe less of a priority issue. Maybe the opioid epidemic was not as much of a problem as, for example, motor vehicle collision, and something that they wanted to address. And so I think that that's one of the challenges we have. CDC does have the Tribal Advisory Council, and we listen to priorities from tribal leaders and representatives from different areas, but sometimes it just doesn't always match up. Not every funding opportunity will match with exactly what every group will need.
Thank you, Dr. Evans. Dr. Gonzalez?
Oh, once again, I will get in trouble here, but I have stayed away from this idea of research and privately funded research and coming. And as Dr. Evans say, I'm staying with my IHS and CDC funding that just do my program and just what I do, serve the communities. But when everybody wants to research tribes, as some of our elders and tribal leaders I have heard and said, everybody comes research and goes away. So most of the funding for research aligns with what the agencies want, and not most of the time what I'm saying agencies, I'm saying funding agencies, not CDC or IHS, please. But does not align with tribal nations' need. The approach, from as what one of my previous CEOs used to say, the dominant society imposed the topic, and we know better what you need. So let's research this. So what happened? I will love, and I invite people. I say, hey, if you have a proposal to do community-based participatory research, and come and talk, do a tribal consultation, and we come out from there, that will be excellent. But so those are the least opportunities. So I'm staying away from that.
Thank you, Dr. Gonzalez. Ms. Lustin, would you share your perspective on the accessibility of research funding for public health issues among studying public health issues among tribal populations?
Yeah, and I do agree, you know, and it has gotten better for sure. And, you know, on paper, it's out there, but it is generally piecemealed and with an already set agenda, as Molly had mentioned, you know, study this topic for X amount of years, or do this work for X amount of years. That agenda is not set by the tribal agenda. Instead, it's set by the federal agenda or the organizational agenda. And also, there's not a lot out there that's allocated to multi-year projects that are stable and give that stability to build up real capacity within tribes. And, you know, we can see this in certain funding sources that have been established for about 11 years now, that funding starting with 250,000, and it has grown as it's built capacity at an organization, and it's up to, you know, $1 million being awarded to an agency because they have the ability to do that. And they have the ability to do that much better than a non-tribal organization or tribe. And I think, you know, there's one area that not a lot of research and action are being done, and that's within the social determinants of health. I think that, you know, as a nation, we don't know how to deal with the social determinants of health. They're there, they're talked about, but not in a way, because it's so upstream that I think the United States can even wrap its head around. And on the other hand, some academic partners will include tribes in their grants. And this work is really done on a peer-to-peer basis where relationships have been formed. And where relationships are developed, very real good research can happen between the RTIs out there and federal entities on there. You know, like I am in very good relations with multiple people on this call, and we know and trust each other and know that we can build work together. And then lastly, tribal leaders have long sought for set aside funding for American Indian and Alaska Native work. This is for at least two reasons. One, it's a treaty responsibility to work directly with American Indian and Alaska Native tribes. Tribes have government-to-government relationships with the United States government, and that trickles down to working with governmental organizations like the NIH, like SAMHSA, like CDC, and every other one. And as such, it's really important to have opportunities specifically for American Indian and Alaska Native communities, because many tribes, many tribal organizations do not have the ability to really compete with academics, states, and research organizations in grants. And that is because of the actual number of American Indian and Alaska Native people available for the research, because of, you know, genocide that has happened in America, and actually the ability to write grants with a month or 2 months notice within a tribe or tribal organization.
Thank you, Ms. Lustin. I'd like to focus our conversation just a little bit on the COVID-19 pandemic. I'm curious how the pandemic has impacted the work that you do in the field of tribal public health, or just in the field in general, based on your observations. Dr. Weiser, would you start us off by sharing your experience?
Sure, I have a couple of thoughts about that. One, and I think many of colleagues I work with at the Tribal Epicenter and maybe even on this call too, one of the first things that happened was everything that we were working on stopped. And before the pandemic, I was working on things related to the opioid epidemic and maternal child health and immunizations and lots of other things. And all that came to a screeching halt as we pivoted towards addressing the pandemic. And so that was one of the things that, we started noticing as the pandemic wore on, was that a lot of work isn't getting done that we were doing. And particularly in some of it, in clinical settings too, such as screening for cancer and immunizations and those kinds of things. And those of us who had been working on some of those things started noticing, hey, we need to get back to that work in the clinics, but also in the research and public health realm as well. On the brighter side, though, we saw tribes that had never really been involved in case investigation or contact investigation really step up to that challenge and work with our organization, with states, with counties, in ways they'd never really worked with them before. And we had training opportunities to help them ramp up that capacity, and they took it on and they made it their own. And I thought that was actually one of the really interesting and impactful changes that happened, is like this very fundamental public health service began to emerge from tribes that before maybe had always relied on their local health jurisdiction in their county to do that kind of work. And now tribes over and over again said, no, we want to do that. We want to do the contact tracing for our tribe. No, actually, we want to be in charge of the immunizations for COVID-19. And we want to handle the testing for our tribe. And so both clinically and in public health, tribes really stepped up. And I thought that was one of the very interesting things. And then finally, I think, like I said at the beginning, I've been here since 2007. The fact that I had been here so long meant that it was a lot easier for me to reach out to people. And because over many, many years, we've been able to build up those relationships to be able to plan for a response, or, work out some of the kinks that developed and move forward. And I think if I had not been in place for such a long time, if I had just walked in, on day one, it would have been really, really hard to establish that. So that's not there.
Thank you, Dr. Weiser. Dr. Evans, are there pieces that you could add, given your role at the CDC around the COVID-19's pandemic, both on your work, but also the broader field of tribal public health research?
Sure. Well, I just want to piggyback on what Dr. Weiser said in terms of tribes, sort of, starting to take on more ownership of some of the public health functions. And certainly for CDC, I think that COVID really gave us a unique opportunity to work with tribes that we had never worked with before, that we did not previously have relationships with. And I think, it was really beautiful to see how tribes were able to use the government to government relationship and work directly with CDC, and tribes that previously just were not really working in the public health space. And so that has been really fun and exciting. And then I also think at CDC, we have now had so many more staff members who have experience working with tribes at all. So before, there were not very many people who even understood what tribal sovereignty was, who had any idea of what it was like to work with urban Indians, or go to a reservation and work on the tribal lands and what, what it means to do that. And so I think that we've also built our own capacity. We've certainly broadened it now with more people, and really emphasizing through those deployments and through the work at our Emergency Operations Center, the importance of cultural humility and, learning to work respectfully with tribes. So yeah, I just wanted to follow up on what Tom said, because I think that's exactly what we're seeing too, is just more tribes have come to the table, and that's exciting for us.
Thank you, Dr. Evans. Dr. Gonzalez, would you like to shed some light on how the pandemic has impacted your work, or more broadly, the field, the field of tribal public health?
Oh, yes, thank you. And this is the demonstration that I'm not negative all the time. But unfortunately, or fortunately, this situation brought to the attention of people, lawmakers, policymakers, the lack and need of data access. I mean, it was not just simply states, but suddenly people started figuring out that everybody just needs data to access data in an efficient way and really quick, and the data was not clean, and all those things just came to conversation. And then finally somebody just figured out, like, oh, how about tribes? How about tribal epicenters? I'm like, there you go. I mean, our friends at CDC and IHS just help us just to raise our voice, but I was pleasantly surprised when suddenly policymakers, lawmakers, senators were just reaching out and said, like, hey, do you have what you need? I'm like, huh. Oh my, I felt just like, sure. So in a year span of time, we were offered at least the access to data sources that they were not yet offered or tested with tribal public health. So I think that if we continue the momentum and we continue the conversations and continue working alongside the federal agencies that collect the data and closer with states, the effect on tribal public health will be immense, thanks to an unfortunate situation that show everybody that we need data.
Ms. Lustin, anything to add, given the COVID pandemic? How has that affected your work and more broadly the field of tribal public health research?
Yeah, I'm going to be like everyone else in that it's actually opened up a lot of relationships and made people, both from the tribal side and federal side and state side, like talk to each other more. I think that also one of the things that has happened, one of the silver linings is that a lot more can be done remotely, and it's acceptable for it to be done remotely. And that's not only telehealth, but actual research that's being conducted. It's more virtual than ever before, which is really important when dealing with a highly rural network across 37 or 8 different states. So you can now do research with, reaching all of those areas, recruiting American Indian, Alaska Native people throughout. The ability to reach all of those people with a survey is like immense. All of a sudden, I don't really love statistical power with Native populations, but all of a sudden you can actually reach statistical power because of what can be reached or who can be reached remotely. Now, the problem with that is, of course, trying to figure out how to deal with the bots in a survey. If you're not doing, focus groups or listening sessions or interviews, if you're actually doing a survey that's out on social media, they can be easily hacked. Why they're hacked, I don't know, but it happens.
Dr. Bell, would you like to round out the question with your perspective?
Yeah, I mean, my colleagues have done a wonderful job responding to this. I would agree with everything they've said. I would add to this. So I started out mentioning a project that I was part of called the Native Pathways to Health, which was a kind of a tribal community health assessment that we did. And it was done, actually the report was released soon after the pandemic outbreak. And so, going back and looking at that report, you recognize some of the priorities, the health priorities that the tribes mentioned when the data was collected before the pandemic, recognizing that a lot of that emphasis has now changed. But also, I think, giving them a little bit more clarity on some of the underlying issues that are impacting their communities. I will say too that the other issue that I've run across is, so we were putting together a grant to submit to look at HPV vaccination in our youth here in our state, and we had to go through the tribal approval process. And it was challenging for me to approach our tribal leadership and say, hey, I know you've got all this going on with COVID, but here's another issue, a vaccination issue actually, and our tribe unfortunately has had tremendous problems with getting our tribal members vaccinated because of personal hesitancy. And so that sort of presented a challenge to me, just saying, I'm asking them to kind of divert their attention off of COVID, but then also to think about another vaccination issue and some of the challenges in getting people to get vaccinated.
Thank you, Dr. Bell. I want us to build on this idea that, COVID has kind of opened up both the data and the infrastructure around tribal public health, and talk a little bit about health equity. The federal government has a growing focus on health equity, and I'm curious how that has impacted the work that you're doing or hoping to do. Dr. Evans, would you begin our discussion?
Sure. So I think that the pandemic happened, at a time when we were having growing awareness of health equity issues. And, certainly at CDC, we've identified that we have a lot of growing to do. And so the pandemic opened up opportunities because I think, because those conversations were going on about health equity, and the pandemic was happening and it was hitting American Indian and Alaska Native populations very, very hard. Together, I think that really allowed us to have an even stronger response and have a lot more attention at the higher leadership levels. Very early on in the response, people were reaching out to find out, how we can better serve tribes. And that's why we developed the tribal support section within our emergency operations center. And it kind of grew, initially it was just it was called the tribal desk, and it had like 4 people on it. And then, and it grew and grew. And now, there's like 30 people who are at the headquarters level, and then people who are deploying out to work with tribes directly. And so I think that just speaks volumes of the fact that the leadership recognized that this was an important population to focus on, and then followed up with that by giving us the staffing to do that.
Thank you, Dr. Evans. Dr. Gonzalez, anything to add here?
Just brief, and I want to echo what Dr. Evans says, that what it gave me was hope. I mean, it has not affected anything else, but just gives me hope that we will continue the momentum. The momentum will just be kept, and we will just continue addressing this, because as I have said publicly before, these disparities and inequalities, they were there before. The pandemic just simply did a slow time trick. And since people were busy staying at home, they couldn't look anywhere. So they have to start seeing really uncomfortable truths. So let's just, just simply hope that this will continue, and the efforts and the great job that our federal partners are just doing, they will be converted in something that is sustainable and just not just simply the response for COVID. And hey, we all have really, really short memory span here. So anyway, thank you.
Thank you, Dr. Gonzalez. Ms. Lustin?
Can you hear me? Okay, I thought I disconnected. There has been a lot of recent history, within the past 5 to 10 years, talking about health equity, a lot like social determinants that I talked about earlier, but really no action around it. Some research, but not much being done. But there are signs that this could be changing. Achieving health equity, though, really requires some hard work and choices by policymakers and leadership. In Native communities, it means acknowledging traditional knowledge, which is generally not considered evidence-based. I got comments back recently when talking about traditional knowledge and indigenous developed interventions, not being good enough, not being evidence-based, because it wasn't based in Western knowledge. And that needs to be changed. And it means allowing communities, all Black, Indigenous, all people of color, to do their own work to achieve this, and not having it be directed by somebody from the outside. So I think, broadly that's needed. And then, just super specifically, you can look at the Indian Health Services funding as an example. The fact that the general expenditure for medical care is in the United States is over $9,000 per person. In the Indian health system, it's $4,000 per person. And friendly senators have noted, that the IHS is dysfunctional because it's underfunded, but its dysfunction is why it's underfunded. The understanding of you can't have a capable system no matter where you are if it's not funded appropriately to take care of its people, and to build a real important health system. So again, policymakers, leadership needs to be making decisions to, at a bare minimum, provide the Indian health system with enough funds to build a public health system, medical system, and elevate American Indian and Alaska Native health. Because it's disgusting that American Indian and Alaska Native people gave away all of their land in return for certain things like healthcare and education. And yet we have mostly some of the poorest health, lowest graduation rate from high school, lowest income because of that. So I mean, health equity for many groups of people are a real thing, and it takes, it's going to take those hard decisions by people to actually, not just to do research around health equity. There are some solutions that are just sitting there waiting to be signed.
Thank you, Ms. Lustin. So we have 4 minutes left, and I was hoping we could open it up for a very brief discussion among the panelists. Our final question, and I first want to apologize that we haven't had a chance to take questions from the audience, but our final question is focused on hopes and visions for the future of tribal public health. We've talked about obstacles and challenges and areas where health equity has become an enhanced focus, as well as the impact of the pandemic on both data collection and our health and the health systems that tribal peoples access. So I'd like each panelist to give 2 sentences on, if they could, on their hopes and visions for the future. Jessica, would you mind if I started with you, Ms. Lustin? Oh, I think you're still on mute.
Sure. I mean, very simply, I think that my hope and vision for the future for American Indian and Alaska Native healthcare and public healthcare is a fully funded system, so that the people who have devoted their practice, their work, their life to working in Indian country can see some real change and be hopeful for the future themselves. And then regarding research, my hope is that there are more American Indian and Alaska Native people doing research and doing programs themselves.
Thank you, Ms. Lustin. Dr. Bell, would you mind going next?
Yeah, I would just add to what Jessica said, is that I would hope that we have the ability in the future to go more upstream to look at some of these issues that have the downstream impacts that we're seeing, and be patient enough to allow those addressing those upstream factors to manifest into the health equity that we would desire.
Thank you, Dr. Bell. Dr. Gonzalez, would you offer your thoughts?
I just really would like that the momentum continues and tribal consultation is done really in a serious way. So research agenda can be planned. So to respond and develop research that is responsive to the tribal needs, and not the other way around. So that's my hope. Thank you.
Thank you, Dr. Gonzalez. Dr. Evans?
Sure. I think what I'd really like to see is Indigenous-led workforce development. I'd like to see more Indigenous people going into public health and becoming leaders in public health. And, I think it's great, like I said, at CDC that we expanded our capacity, but I'd like to see that with more Indigenous people at the lead.
Thank you, Dr. Evans. And Dr. Weiser, would you mind sharing your hopes and visions to conclude our panel today?
Sure. So I think we talked a lot about the gains and the new capacity that tribes and tribal organizations have developed because of the pandemic. And so one of my hopes is that we continue to build on that it goes forward. Molly mentioned Indigenous public health workforce. We've sort of created one. It's happened, and we need to support that and help it to grow, because we didn't get a chance to talk about this, but I'm going to. We have a much greater challenge coming at us, and that's climate change. So if the pandemic was any sign of our ability to work together and meet a major challenge, it's just a warm-up for what's to come. And tribes, many of them are on the forefront of the areas that will be greatest impacted, through whether it's through forests or on the coasts. And so we're going to need to really build up that capacity to prepare for the future.
Thank you, Dr. Weiser. I want to thank our panelists for their efforts today, as well as Sarah Hatchard and Katie Cretin, and the wonderful team at RTI supporting today's webinar. We will attempt to address audience questions when we send out the recording. And thank you again for your participation and your interest.